All right, thank you so much. I appreciate your attention. This is a topic that's near and dear to me. The picture on the left is one of my favorites, the old school way of debriding the pancreas with a ring forceps. And I describe this as like old motor oil coming out of this space, which if anyone's changed their oil filters is what it looks like sometimes. So I have no financial disclosures, and I'll give the required 7-second pause, but I'll continue with. So you have to watch out for pancreatic necrosis, and it's not too dissimilar to this picture of the bear hiding behind the tree. You see the necrosis, and you hope it just literally stays there, but every once in a while it's going to reach out and come after you. And so this is what we see on a daily basis, and I think most of the people in this room have seen components of this. So the outline of my brief presentation will be looking at the data that are present through prospective clinical trials, touch up on a couple key management points that we don't have prospective data for, and then a very brief but specific review of existing societal guidelines. So I call this the dawn of the new era. I love this study. This is my favorite study, primarily because it literally has a table and one figure. This was published in 1997, coming from Mexico City. And the beauty of this is the simplicity of what these providers did. And I'll just get to the table. So on the left, you have patients who underwent open early debridement, had 25 patients, and the associated mortality was between 50 and 60%. And on the right, you have the late debridements, presumably in that era just were debrided because the patient was fine initially, they were managed medically and to the best of their abilities in that era. And then they showed signs of requiring a debridement, and the mortality was dramatically down to 27% in this study. Now, these are small sample sizes. I love the description of alive versus death, but that's how beautiful. And so I consider this the night, and this is the day, okay? This literally changed many of our practices, for those of us who were treating this 20, 30 years ago, and our approaches for necrotizing pancreatitis. Now, the Panther trial, as everyone's familiar with, published in 2010, this became more specific and even with better outcomes. Imagine from 1997 to 2010, none of us were really doing all that great. We all had our opinions, modest amounts of data for people to share and publish, all small series, single institution series. But this was really outstanding work by the Dutch Pancreatitis Study Group. We know many of the individuals on this and who have continued to be productive. And I'll just highlight sort of the principal endpoints. What their data showed is that there was an improved morbidity without having to do an open necrosectomy. So if you look at their primary composite endpoint was major complications and death. In the minimally invasive step-up approach, it was 40% versus 69% in the open necrosectomy group. Specifically, there was a lot less multiple organ failure in these patients. Now, coincidentally, no real change in expected mortality. So of the patients we were able to rescue, they did better with a fewer number of open necrosectomies. Now, that's painful for a pancreas surgeon to see, but if anyone who's ever debrided a pancreas openly, it's not a pleasant operation. In fact, it's an operation you want to forget about as soon as you leave the operating room and hope that the patient does great. Now, fast forward 8 years in 2018, the Dutch Pancreatitis Group published this paper, and I refer to this as "The Sun is Shining Bright," where it was a direct comparison to direct endoscopic necrosectomy versus surgical in this same step-up approach. So both groups still benefiting from lesser invasive approaches to treatment to infected pancreatic necrosis. And really what they found was that endoscopic necrosectomy had fewer long-term pancreatic fistulae and shorter length of stays. There really was no perceived difference in morbidity and mortality. But, I remember, this is what, 6 years ago? I remember in the era in 2017 where it was a long discussion with our gastroenterology colleagues, and they were very excited to do it, but they didn't know where the data was going to take them. And so this was probably, in my opinion, the first manuscript that said it actually is safe, it is reasonable, and it's taking the scalpel out of the surgeon's hand, so to speak. Now, let's segue to the discussion of prophylactic antibiotics. There have been multiple studies on this. This is probably the best, most well-studied component of pancreatic necrosis therapy. It was a seesaw back and forth, but I think it's been pretty clearly shown that the initiation of prophylactic antibiotics did not prevent sterile necrosis from becoming infected, or other permutations of the development of infected pancreatic necrosis. I think avoiding the pneumonias, avoiding the cholecystitis, avoiding urinary tract infections, that's probably more valuable than prophylactic antibiotics. Multiple randomized double-blind placebo-controlled studies, both in GI and the surgical literature. And if anyone's curious, that's the composition of meropenem there in the bottom. I had to add some color to the picture, but enteral nutrition, very clear that enteral nutrition is superior to parenteral nutrition. In most cases, there are selected patients who might not. This is the one good study in digestive surgery in 2006 that randomized severe acute pancreatitis patients. Those with enteral nutrition had fewer infections, less multiple organ failure, less mortality. So I think everyone has, for the most part, agreed upon this one. All right, so now let's get away from prospective data. Honestly, the amount of prospective data we have in this particular domain is better than most surgical diseases. And I think that's why we've seen such a dramatic change in the last 2 decades in the management. In this particular topic, visceral artery pseudoaneurysms, which really is the main harbinger for mortality, in my opinion, we have no prospective data. It's all meta-analyses and retrospective series. We believe the incidence is somewhere between 1 and 10%. In locations, usually the splenic artery, maybe the left gastric as a surrogate of that, definitely the gastroduodenal arteries, and sometimes the pancreaticoduodenal arcades. Now, therapy usually is embolization and selective stenting for high-risk areas like the common hepatic artery. Usually the interventional radiology colleagues are successful. The main morbidity is repeat hemorrhage, which I think we've all seen. I think my singular patient that had to get embolized 4 times, all different branches, that was probably the record that I've seen. I'm sure there's been more than that. But these are the patients you need to watch out for because these are the ones who actually have the chance for mortality with 20 to 35%. So pretty significant. Also, mesenteric venous thrombosis, very big problem. No prospective data, meta-analyses, retrospective series only, somewhere between 16 and 23%. Usually it's a splenic vein. We've all seen splenic vein thromboses. Sometimes the portal vein, those patients can struggle. And then we've seen all other, IMB, et cetera. Usually it's at the site where the necrosis burden is greatest, not always. So the therapies are usually systemic anticoagulation, seldomly for very severe thromboses. You can do percutaneous stenting and thrombectomies. I try to avoid this though, but I'd be lying to you if I've never had to do this in one of our patients. And actually putting a percutaneous drain in the necrosis, even if the timing is early, can offset some of the pressure on whatever vein that is thrombosed. Actually is an important key detail to consider when you face these problems. All right, so let's briefly go through societal guidelines. So there's multiple societies that have done this. I've kind of listed them there. I'm actually going to go through them real quickly. They've had varying levels of recommendation strength based on the data provided. There is a lot of crossover. It's probably good that multiple guidelines had similar conclusions as opposed to widely different conclusions. So let's start with 2013. The IAP and APA were the first ones out the gate. And they've established in these guidelines, a lot of the things that we, I think, sort of take for granted of believing and knowing to be true. So for instance, how to achieve a clinical diagnosis, combination of symptoms, lab findings, imaging. The recommendation for repeat imaging, it's somewhere between 3 and 4, sometimes 7 days after initiation of pancreatitis symptoms, and especially to repeat imaging with clinical deterioration. Things like resuscitation, no prophylactic antibiotics, and then early enteral feeding for severe acute pancreatitis. I think we can all agree to those that the data are clear. Now, what was interesting was that they went a little bit further and they okay, as we assess these patients, this was the first time someone said, clearly, you don't need to do an aspiration of a fluid collection to determine whether it's infected or not. That by image findings, you should be able to determine this to be infected and treat it accordingly. Also, having a fluid collection and having multiple organ failure also as a by proxy, by defined infected pancreatic necrosis. And so this was probably the most major finding of these guidelines. They did the first ones to just actually put a little more credence to the delay of all intervention types beyond 4 weeks when possible, and then highlighted the role of percutaneous and endoscopic drainage before surgery. Now, East in 2017 tackled this, looking mostly at surgical series, which were probably not as robust data-wise, but their conclusions were delayed timing necrosectomy lowered mortality, surgical necrosectomy only if other options failed, and then definitely minimally invasive necrosectomy that reduced morbidity and mortality overall. AGA, also in 2018, theirs was moderate quality of data. None of them achieving high quality, but they agreed to enteral feeding by mouth when possible, next enteral feeding via enteric access over TPN. And then they did go out of their way to say that cholecystectomy during index admission for biliary pancreatitis felt that patients overall did better. All right. Now this is the most recent and probably the most robust of the guidelines. World Surgery of Endoscopic Surgeons, 2019. They focus more on the severity of it and then the potential emergency surgical management. So I'll kind of briefly go through these. So they felt that there really wasn't a singular scoring system that could predict severity better than the other. That if you stuck to this is severe acute pancreatitis, fluid collection, multiple organ failure, those are the patients that were going to struggle and potentially have a mortality. And those with persistent multiple organ failure were the ones that carried that greatest mortality. They focused on diagnostics, certainly do right upper quadrant ultrasound as the primary initial test to determine biliary sources for pancreatitis, CT scans to assess the anatomy, and then MRI or endoscopic ultrasound when the etiology of the pancreatitis was unknown. Now, this was clear that this was timed when appropriate, not actively when the patient is ill. And that is if an etiology was not discovered. They focused on interesting finding about having a super high hematocrit as a predictor for necrosis. Repeat imaging after 7 to 10 days to assess for necrosis after initial admission and for clinical deteriorations. They also highlighted no prophylactic antibiotics. They went further in saying that aerobic, anaerobic, gram-positive, gram-negative coverage for infected necrosis when confirmed, have to find an antibiotic that penetrates the pancreas, and they did not feel that there was data supporting antifungal prophylaxis, even when confirmed infected necrosis. They agreed upon ICU level of care with appropriate fluid resuscitation, not even aggressive resuscitation. They also agreed with enteral feed when possible. But here's probably the most interesting part, and prior to this, the least discussed was, okay, so now you have a patient with pancreatic necrosis, intra-abdominal hypertension, literally should try all non-operative therapies before a decompressive laparotomy. If you're forced to do decompressive laparotomy, they felt the data were very clear that you should avoid doing the debridement. That's kind of counter to what I would think, but I would be lying to you if I've never done decompressive laparotomy and debrided the pancreas at the same time. They believe in negative pressure peritoneal therapy or the Abthera type approach, and then re-exploration within 24 to 40 hours, and then early fascial closure. I actually thought this was a great touch. As an HPB surgeon, I don't really think along these lines. I do take call, I do emergency general surgery type cases, but I never put it into context. So I think they did a very nice job doing that for all those who take care of these diagnoses. So in summary, I think the evaluation and diagnosis of pancreatic necrosis is clear. We have evolved greatly in 2 decades. It's one of the most impressive things I've seen in my own career, like how the seasons have changed. Typically, percutaneous drain for intervention when it's less than 4 weeks. Delayed intervention is preferred, even over that, for greater than 4 weeks. The minimally invasive is preferred over maximally invasive. Direct endoscopic necrosectomy and other MIS necrosectomies are ideal. And then open necrosectomy still has a role, but it's literally when everything else fails and there's potentially another indication for GI surgery. Perforated colon, uncontrolled fistula of some variety. So there's still a very narrow window for some of us. I want to say thank you and for Sage's opportunity to share this description. I thought that the picture of the clips in my backyard, I was celebrating with a glass of champagne, was perfect for a segue into the management of pancreatic necrosis. But anyway, thank you.